Impingement is a common cause of shoulder pain. It is a consequence of progressive injury to the rotator cuff in either work, recreation, or activities of daily living. It occurs most commonly when the shoulder is repeatedly employed at or above shoulder level. In order to best understand impingement, a brief review of shoulder anatomy is helpful. The shoulder is a drumstick-shaped bone which articulates with the shoulder blade or scapula. From the different surfaces on the shoulder blade, a series of muscles originate and then join together to form a cuff of flat tendons. This cuff attaches then into the lateral aspect of the shoulder. The top tendon, although the smallest, is both the most important as well as the most commonly injured. Due to its importance and predisposition to injury, we will, for our purposes of discussion, call this small superior tendon the rotator cuff. A bony arch called the acromion, or roof, covers the shoulder and protects the rotator cuff tendons which slide back and forth beneath its curvature. Over time, however, a bony spur may form on the front of this roof. As the spur enlarges, it may project downwards and over time may abrade, injure, and tear the underlying cuff tendons, a process called impingement. It is helpful to simplify shoulder anatomy by visualizing it in cross-section, as shown in this slide. This two-dimensional drawing illustrates the roof, or acromion, the rotator cuff muscle, the cuff tendon attaching the muscle to the shoulder, and lastly, the shoulder joint itself. The reduction of complex shoulder anatomy into a simpler, flat, two-plane image is the basis of MRI imaging. This simpler approach to shoulder anatomy will be used throughout this presentation. The rotator cuff exerts downward pressure on the shoulder, keeping it positioned within its joint. This in turn creates room for the muscles and tendons to glide beneath the bony arch. The cuff also provides an important mechanical advantage to the larger surrounding chest and shoulder muscles. In impingement, however, the rotator cuff becomes a less effective shoulder depressor. Though the shoulder will move superiorly only a small distance, as we will see, this may be enough to produce injury and pain. Impingement occurs when the rotator cuff tendon comes in contact with the roof of the shoulder, and as a consequence becomes abraded, roughened, and thinned. Clearance between the cuff tendon and the acromial spur decreases with age. This follows the progressive enlargement of the acromial spur, which originates from the front of this bony roof and projects inferiorly toward the cuff tendon. Injury will also affect rotator cuff function, leading to further decreased clearance and further injury. Acute or repetitive injury can further impede rotator cuff function. In turn, this allows the shoulder to migrate superiorly and abrade against the acromial spur. In this case, a vicious cycle ensues. Injury leading to superior migration, leading to cuff injury, which in turn leads to increased migration, and then further injury. The process of impingement ultimately results in rotator cuff pain, which is characterized as anterior shoulder pain which radiates into the upper arm and is generally aggravated by shoulder level or overhead activity. Rotator cuff pain, however, is not specific to impingement, but indistinguishable from pain secondary, for instance, to biceps tendon injury, primary cuff degeneration, and partial or even small full-thickness cuff tears. Fortunately, the treatment of biceps tendon and rotator cuff injuries noted in the last slide involves the same frequently successful combination of anti-inflammatory medication and strengthening used to treat impingement. If the patient continues to have pain despite adequate conservative care, we can suspect the presence of severe impingement, but ultimately the diagnosis must be confirmed by arthroscopy. In summary, the shoulder is normally held inferiorly by the rotator cuff, providing clearance between the tendon surface and the acromial spur. If impingement is significant, the surfaces of the acromial roof, and often the tendon itself, will show mechanical signs of abrasion and wear. In this slide, there is no evidence of impingement. The surfaces are smooth and reflective. Normally, as depicted on the previous photograph, there is no evidence of contact between the shoulder roof and the cuff surfaces. In this video, the surfaces of the roof and rotator cuff are similarly reflective and smooth. You needn't be an orthopedist to note the absence of surface abrasion and therefore the absence of clinical impingement. On the other hand, repetitive mechanical injury to both the surface of the cuff and acromial roof characterizes severe shoulder impingement and is well documented on this slide. In this video, both tendon surfaces and roof are abraded, roughened, and frayed, confirming the diagnosis of impingement. When pain persists despite conservative care, arthroscopic treatment of impingement is generally considered. In the absence of significant rotator cuff injury, arthroscopic removal of the projecting spur, a procedure called decompression, effectively alleviates pain for the great majority of patients. Other injuries commonly associated with impingement can also be treated during the same arthroscopic procedure. The indication for arthroscopic decompression includes failure of conservative care, chronicity of symptoms, limitations in work, exercise, or activities of daily living, and of course pain. Complications include those of any surgery, infection which occurs in 1 in 100 patients, recurrent pain which occurs for all reasons in 15% of patients, nerve or vessel injury which is extremely rare. The general complications of anesthesia, stiffness, which can follow any shoulder surgery, and which, if present, can prolong recovery and even require a second procedure. The results of arthroscopic decompression are quite good. 85% of patients report good to excellent pain relief. Return to work varies in regard to the amount of lifting and overhead work requirements. Return to athletics generally occurs between 6 weeks and 3 months following surgery. The procedure is performed as an outpatient at Hackensack University Medical Center, same-day unit. Regional or general anesthesia is utilized, and most people require only a few days of postoperative pain medication. Postoperative recovery involves a few days of sling use, physical therapy, with general full recovery and return to sports and work between 2 to 3 months. I hope this presentation has been informative. In the ensuing consultation, I would like to discuss with you the method of a treatment appropriate for your shoulder. Thank you.